Well, welcome to the Interventional Cardiology Virtual Education Summit presented by Johns Hopkins University School of Medicine at CardioCare Live. My name is Dr. Chris Cannon, and you're tuned into a live session called Aortic Stenosis, a focus on TAVI, or TAVR. And I'm joined by two experts in the field, Drs. Jeff Moses here in Boston and Dr. Papa is here in Boston, and Dr. Jeff Moses at Columbia in New York. Delight to have two colleagues that we will be discussing one of the hottest areas, I think, in cardiology now. Dr. Patma is the Director of Innovations in Interventional Cardiology and a senior attending physician at the Beth Israel Deaconess Medical Center here in Boston. He's an associate professor of medicine, although professor, right?
Professor now.
Full professor, okay, of medicine at Harvard Medical School. And Dr. Moses is the director at the Cardiovascular Interventional Cardiac Cath Lab at Columbia University Medical Center, my alma mater, and also professor of medicine at Columbia University College of Physicians and Surgeons. Now, before we get started, I'd like to remind you that we'll be taking questions throughout the program, and so you can type them into the box. And so you can send these questions in, and we'll try and intersperse them during the program to make this interactive and address questions that you'll have. And so with that, I'll begin, and we'll turn it over to Jeff Moses in New York to set the stage for TAVR and how this has become really one of the biggest areas in interventional cardiology. Jeff?
Hi. Good afternoon. It's great to be here. I'm just going to sort of give you a 10,000-foot view of the state of transcatheter aortic valve implantation, and also just review some of the really key data points involving the two major valves. As we know, this technology has really exploded. There are two major valves in use. One is, of course, the Edwards balloon expandable, and the other is the self-expanding Medtronic core valve. There have been over 50,000 implants worldwide, over 600 centers, so this is hardly a new therapy. On the academic front, there's an explosion. In 2012 alone, there were over 370 peer-reviewed articles published in this field, and it's obviously a booming area of clinical research. At Columbia, we have seen this reflected certainly in our case numbers, and we're now heading towards 600 cases total, with over 350 done just in the previous year. And in Europe, where, of course, the device has been embedded and approved for many more years, by the latest surveys, almost 25% of all aortic valve replacements in the 11 European Union countries performing this procedure are actually with transcatheter procedures. And as a matter of fact, last year, the valve procedure has actually been incorporated in the guidelines of the ESC for valvular heart disease, with a Class 1 indication for patients not suitable for AVR, and a Class 2A indication for those who are at high risk, who are also surgical candidates, pending a heart team assignment to one therapy or the other. Now, when we look at the spectrum of aortic stenosis patients, of course, and this is, we're learning about this, we remember that we found that 1/3 of patients who were eligible for valve replacement because of severe symptomatic aortic stenosis in multiple surveys were not receiving it. Now, some of them were just simply too sick with too many comorbidities, and we call these cohort C patients who are really too sick for any therapy where it's futile. However, the group where there's no equivocation about its use is, of course, the extreme risk or the inoperables, and we'll review the evidence for that in a minute or two. Then, of course, we have the high-risk patients who really constitute the top 10% of the risk stratum of patients currently going aortic valve replacement, and that was the so-called Partner 1A group. And then, of course, there are the low-risk patients, which constitute really 2/3 of the patients who are even today and for the foreseeable future, strictly surgical candidates. In the middle, about 25% of the patients we call intermediate risk, and we believe there's equipoise in that group. And currently, those patients are undergoing randomized clinical trials, which we'll touch upon as well. Now, in terms of the evidence on which these current recommendations are made for the use of this technology, they stem from several areas. The best data, I think, are from the randomized trials and well-characterized registry. I'd just like to review what we found with the partner trial. These have been four publications in the New England Journal, really reviewing the partner data with 1 or 2 year outcomes. If you remember, the partner trial were really two trials. One was the so-called inoperable group that constituted 368 patients who were either assigned to medical therapy or to the transcatheter valve implantation. What we found with that cohort of patients is that in 1 year there was a remarkable 20% absolute reduction in mortality, and that extended out to a 24% reduction at 2 years from 68% to 43%. And I think this is quite important because these were very sick patients, and there was always concern that their ancillary comorbidities would really overwhelm the effect of the valve disease, even if you fixed it, and this turned out not to be true. And as a matter of fact, if you look at a landmark analysis, after 1 year, the mortality is cut in half in that second year from 35% to 18%. And of course, these data led to the approval of this valve in the United States. I think importantly, though, we have to realize that even within this group, there were 1/4 of these patients with an STS above 15 who really gained no benefit from this treatment. And I think this would put those patients in what I would call the futile category. But of the group that we did randomize, fully 3/4 of them with STSs below 15 certainly had a remarkable reduction in mortality of more than 50%. The second arm of the trial, of course, was the so-called 1A, and these were high-risk patients with high STS scores who were randomized to conventional aortic valve replacement and, of course, the transcatheter valve. And what we found at 1 year is that the mortality rates were 26% with surgery and 24% with the percutaneous valve. And very encouragingly, now that we have extended data as far out as 3 years, the mortality curves actually are superimposable. I think a remarkable finding, however, in this study is that, at least in women, the mortality actually seems to be lower with the transcutaneous valve than the surgical replacement. So this seems to be a particularly good therapy for women, and this has been verified in several other data sets. Now, in addition to that, of course, we have the ADVANCE registry for the core valve. That is, I think, the best data available currently. And that is over approximately 1,000 patients from 44 European centers with very good history of over 40 cases. And they had about a 4% acute mortality and an 88% survival at 1 year. So this is comparable to what we've seen in terms of with the Edwards valve. And of course, there are the randomized trial in the United States with the core valve that Jeff Potma is the PI, which is finished enrolling, and hopefully sometime later this year we'll see how these results emerge pending for approval in the United States. I think what we've seen, though, however, is that when we look at multivariate analysis and we look at survival, we know that patients class 2 or class 3 patients with very high Euro scores, and also those patients with residual aortic regurgitation, moderate or above, seem to be at high risk for mortality with this therapy. And what the next phase, of course, is for us to really drill down on those patients who are at the highest risk for this procedure and who may benefit for surgery. But I think that will also be contingent on dealing with some of the complications of this therapy, which I think Jeff will discuss with us in terms of how we will improve this therapy in the future.
Well, Jeff, thank you for giving a terrific overview of the state of the art currently. We've had a few questions come in. One, I should note that live the slides aren't showing, but they'll be present in the on-demand version. For Jeff Moses's part, we'll have slides coming shortly. But a question came through. Samir Saha asked whether you had any thoughts on why this worked in women. Is there a differential of some of the complications being fewer, which is not a typical thing in women, or they had different baseline risk score that made them more apt to benefit?
No, I think, well, actually, ironically, I mean, the complications in terms of those that drive some of the adverse outcomes, which I think Jeff will talk about, in terms of vascular complications and bleeding, are actually higher in women. But it might be that these women are specifically, frailer, and, there are a lot of these very frail little old ladies, and they just the men tend to be a little more robust, and they just may be more survivable with the surgery than the women. But I think the paradox of the higher vascular complications and the lower mortality is very intriguing.
So Jeff, that was a brilliant presentation. I have a practical question for you, and I know you guys have, as you've said, such an extensive experience. One of the challenges that I still have in evaluating patients is figuring out who needs to be part of the multidisciplinary team to make these decisions about which cohort the patient needs to be in, right? So it's the cohort C that you identify. Those are, maybe we're going to have a better eyeball test for them as interventional cardiologists. The surgeons have had a very good eyeball for that. The high risk versus the intermediate risk is another kind of grayish zone. Do you include geriatricians and non-invasive cardiologists and surgeons and interventionalists in this process? Maybe you could speak to how it works at Columbia for presenting these cases.
Well, I think obviously the surgical collaboration is key for a variety of reasons. Most importantly, the therapy should not be dictated by who sees the patient first, whether it's a surgeon or an interventionalist. I think the imagers are key because, as you know, the diagnosis of aortic stenosis isn't always so simple, especially with these elderly patients with low gradients and normal ventricular function. And I think that's a very key part of it. And another aspect which we've worked on, of course, we have Phil Green in our group, who's one of our senior fellows who's emerged with superb data, is really quantifying the frailty aspect. Right. We've learned from the geriatricians and Linda Fried at Columbia and the like, the frailty score, and we're, as opposed to an eyeball, Jeff, I think we're really trying to work on getting quantitative tools to really decide who will best benefit from this, or where no therapy is appropriate, or frankly where surgery may be a more appropriate therapy.
So along those lines, I mean, you've emphasized the data, and what I would take away from the soundbite of the data that you've done, really for partner B and partner A, is that the 30-day mortality rates are surprisingly good with the transcatheter valve therapy. It's really, really low. But the 1-year mortality rate is soberingly or realistically higher. And you've said comorbidities is there, but could you speak to pulmonary disease? And I know that at least in the Canadian series, that's been the #1 out-of-hospital predictor for mortality. In your experience, can you give us some good guidance about what's really going to predict their 1-year survivability?
Well, I think the pulmonary disease is a predominant issue. Ironically, of course, that's the main reason these people do not become surgical candidates. When you look at the mortality after the acute period, of course, there are heart failure mortalities, and I think that is another aspect of these ventricles that are really, have diastolic dysfunction or fibrosis, and you don't really cure the heart failure in spite of curing the aortic stenosis. But the comorbidities, and especially the pulmonary comorbidities, are really predominant in terms of the late mortality. And what we find is, even though it drives a lot of mortality, the actual quality of life in the survivors is actually still improved by one or two classes. So I think we really need to understand. I think we need to understand this better. One caveat I'll say is the pulmonary patients. I think the transapical approach, I don't think is very suitable for them as a rule, and I think that drives a lot of it. But I think my tendency, obviously, would be for a low-impact transfemoral, maybe non-intubated conscious sedation approach for those patients, and maybe we can even improve those outcomes with those patients.
That's terrific. It's interesting how you say who sees the patient first. It's more people like me who really don't know all these nuances. And in referring patients to the heart team, often the question is coming up more and more, when do you say no for either therapy as likely the best approach for a patient? And it's these multi-factorial comorbidities that tend to drive let's just not rush in to be super invasive.
I want to get Jeff's feeling about this, because I have used balloon valvuloplasty has always gotten such a bad rap. I mean, since the 1990s, when we had outcome data say you don't live longer with balloon valvuloplasty, there's been this feeling that it doesn't do much good. I actually think it does a lot of good, for me anyway. I mean, a lot of patients who are in the cohort C symptomatically do improve. We don't necessarily think they're going to live longer, and we know they're all probably going to reach stenosis, but at least their symptoms are a little bit better. And it has allowed us at least to figure out if these patients can tolerate the stress of even a balloon valvuloplasty in order to understand whether they'd be good candidates for transcatheter valve therapy. So, I mean, Jeff, what's your feeling about balloon valvuloplasty in these patients who you really can't decide if they're appropriate candidates for transcatheter heart valves?
Use that very frequently. Interestingly, when you looked, even though the numbers are small, when you looked at the B group, where the vast majority actually had balloon valvuloplasty, it was associated with an improved survival, in spite of critiques of the trial based on the use of balloon valvuloplasty. But we frequently use it as really a test to see whether there will be clinical improvement and meaningful improvement, and sort of bridge them, not to surgery as we used to, but potentially bridge them to the transcatheter valve. Or if there is a lack of improvement and no meaningful quality of life benefit, then we will put them in the inoperable group.
Can I ask Jeff a controversial question?
Yeah.
So look, you've made this juxtaposition of what's happening in Europe, with 25% of the patients getting, transcatheter aortic valves in Europe, for lots of different reasons for that. And then you've also shown us some very, I think, superbly performed randomized clinical trial in the United States that has been sequential in its demonstration of benefit. First from those patients who weren't operable, then to those patients who were high risk, and now into this intermediate group of patients. And my question for you is, and I'm going to look at the emotions on your face to get your reaction to this question.
I'm usually a pretty dead giveaway.
Should the FDA be congratulated in some sense for making us do the studies that nobody wanted to do, so that we have definitive answers? Or should we take more of a philosophic approach and say, let doctors have this technology and see how it sorts out?
Well, I have two feelings. First of all, on the surgical arm, the high-risk arm, I think it was absolutely the right trial. First of all, we learned what surgery is really about. And there were some surprises, and positive surprises about it. And frankly, we forced a lot of surgeons to do surgery on patients they were previously turning down, and they were stunned about how well they did. Yeah. So it opened the door to them, seriously. I mean, the stroke rates, the mortality rates. Remember, the STS score of the surgical arm in Partner 1A was 12. Yeah. And the mortality was 8. So that was. I think that's a key part. I'm not sure. I mean, Honestly, the one, the inoperable randomization, I had some issues with. It had to be done. It got the therapy, it got the therapy out. But as you know, in your trial, you did not have to do that, and I think that's the last time we have to do it. Certainly in intermediate risk. And now I just think you need to understand that. And right now, until the technology evolves, I think it has no place in the in the low risk patients. But I think the FDA forcing the randomization really changed the field.
Yeah.
No, you also
don't you think so, Jeff?
No, I mean, absolutely. I mean, it's the hardest thing to do is to randomize these patients. But that's where you've said the interdisciplinary team is key. I have learned how to explain the risks and benefit of surgical aortic valve replacement very well to my patients, and sometimes it may be the better therapy for them. So I really think that this has been a very important milestone for us.
Yep.
Now you mentioned imagers as a key player in this team, and how much does mixed and mostly mitral valve disease factor into whether you can or can't do TAVR?
Well, there's several different levels to this, and I'll let Jeff speak to the partner data, but we excluded moderate and severe mitral regurgitation from the IDE trial for CoreValve. So if there was moderate to severe or severe mitral regurgitation present, then those patients were not included. And I think that in many ways, a lot of us felt that that was a missed opportunity to study that. The European registry data suggests that at least you improve by a grade, maybe more. And so now we have started an expanded use registry where we're actually studying patients specifically who have aortic stenosis and moderate or moderate severe mitral regurgitation in order to understand whether or not they benefit. And without knowing any data, I think they probably are going to benefit, and maybe that was a bit of a missed opportunity. Functional mitral stenosis is more of a problem, particularly when it's due to MAC. And we have not had severe mitral stenosis due to MAC allowed in any of our studies so far. The moderate is an exclusion, but that's kind of a gray zone. So I think we need to study this because I think the concomitant mitral valve disease does affect it. I'll bet they're going to get better. I think, Jeff, you have some data from Partner in the Core Lab suggesting they do.
I mean, obviously the severe MR was excluded, but as you know, in Core Lab readings, there's always some that get through on the Core Lab as moderate to severe, and there was improvement. And John Webb has demonstrated this as well. And I think our surgeons have known this for a long time. They will replace the aortic valve and then look at the intraoperative echo and reveal that as well. So there may have been a higher interprocedural morbidity, but ultimately they benefit with a reduction in MR.
And it makes physiologic sense, right? You reduce the outflow stenosis, and that's going to make the regurgitation a bit less.
Yeah, I mean, because in the trial phase, like 2 years or so ago, people would be excluded,
correct,
because they had either lots of MR and so that could be less of an exclusion, I suppose.
Right.
But
well, for commercial use, I don't think it is an exclusion of SAPIEN, right, and we are studying it now in the CoreValve trial. So those patients can get in, and they're going to be difficult patients. The other area that's kind of a gray zone is the low gradient, low output, which has really been a gray zone for a diagnosis, as Jeff said. Some of them don't really have significant aortic stenosis, or if they do have aortic stenosis, it's bad because it's associated with bad ventricles. And so either from myocardial fibrosis, if the EF's normal, and if the EF's abnormal, just due to dilatation.
Well, how often do you actually cross the valve and do measurements versus relying on echo these days? I don't
know, Jeff, what are you doing? What are you doing at Columbia?
Well, obviously if they have, an unequivocal gradient, we don't bother anymore. But a very high percentage of these patients have reduced ventricular function, gradients that are in the gray zone. Obviously, we rely on the echo, and we try to get 4 meters per second, which is the qualifying. But sometimes you don't, and we put the hemodynamics together with the echo, and sometimes with some provocative tests. But it's not infrequent, and we do probably cross about half these valves to really delineate the severity.
Well, that's good to hear.
I don't know what
we're doing the same. We're doing the same. I mean, but it's not that we don't I think we've understood the challenges of echo. And that's not to say that the texts aren't good, they are good. It's not to say the readers aren't right. But there's so much physiology that you get out of the hemodynamic evaluation. Right. And Howie Herman has some great data of correlations between very good echo and 3D echo and hemodynamics that I think that's very, very provocative.
Yeah. All right, well, why don't we turn to Jeff, and you can go through some of the real complications that factor in all these discussions of the heart team of you want to help and do no harm, but they'll be sorting that through.
Great, and as long as Jeff doesn't go away on the other end, I may pepper him with some questions along the way as well. Hopefully you can see some of these.
Pepper you?
I've been peppering. So look, I want to focus on five topics very briefly, and one of the topics is more of a philosophic one, and that is that I think imaging is going to be absolutely paramount to improving the complication rates that are associated with these devices. And the aortic valve is centrally located. It's contiguous to a number of very important anatomic structure. The coronary arteries, the conduction system, the anterior leaflet of the mitral valve. And we have certainly learned about all of those because unlike a surgeon who can directly visualize the annulus, resect out the calcification, and understand that they can spare every anatomic structure by direct visualization, we don't have that opportunity. We're actually moving a very disformed and displaced valve out of the way and inserting another valve, whether it be self-expanding or balloon expandable. So we can impinge upon the coronary arteries, that's important. We can impinge upon the mitral valve, particularly the anterior leaflet of the mitral valve. And with the core valve device, and to a lesser extent other devices, we also impinge upon the membranous septum, where the conduction system lives. So imaging is going to be key for us to understand. Now, I always go into very healthy debates with Becky Hahn, who is one of the best echocardiographers on the planet. But I have really moved more towards believing that CT is the way that we can get this very fine definition. So as part of our core valve clinical trial, and I suspect increasingly with the SAPIEN use too, we're moving to CT angiography because it tells us a tremendous amount about calcification, about locations of the coronary arteries. We get very fine details about the annulus. And at the upper screen, you kind of see the aortovalvular complex and calcification within the valve. The extent and distribution of calcification, I think, is going to be very important as we talk about rupture and leaks and all those things. So this is certainly very, very important. And we have moved now to very precise sizing in what we have done with the core valve clinical study. We have 4 frame sizes that are available to us. We've used perimeter measurements to help guide exactly what size valve we take. And we actually try to aim, let me see if I can go back one for this one, previous one, and we try to aim towards having between a 10 and a 20% oversizing so that we can minimize the degree of paravalvular leak. And if we looked at anything retrospectively, we've learned that undersizing the valve predisposes to the occurrence of paravalvular leak. And so we've been very precise with this. Now, we also don't want to oversize because increased pressure on the membranous septum may also predispose to conduction system abnormalities. So I think we've just tried to optimize that. Let me just ask Jeff, what's your take now on CT for annular sizing?
Well, I mean, you mentioned Becky, who's a godsend, and she's a great 3D imager. The key is 3D imaging, I think.
Yep.
And I think for a one-stop shop, I do think a good CT angiogram with the proper protocol can not only just give you the annular size. I happen to like the area measurements only because it's less dependent on wiggles on the perimeter.
You're absolutely right.
And but it's the same concept, and we're really working 8 to 10% range. I think with the Edwards valve, but also you get the iliacs, you get whether it's a porcelain aorta. It gives you a wealth of information, the height of the coronaries. So I really like CT angiography too.
And I think the other kick to this, and this is just the generic message to anybody who wants to get into the field, this respectfully can't go to the radiologist to do, and you take the report back from the radiologist. This is something that you have to have somebody, either yourself or somebody in your imaging group, that embraces this, so that one can actually really understand it yourself. We can't send this off to another external group who's not involved in the procedure. We really have to go through all these details. And I think the best example of this is really where we're using, Jeff mentioned the CT for the peripheral vessels. You kind of look at this straight off the mark and you say, well, this looks great. But the problem for this is that this would not accept a 18 French sheath, not because of the diameter, which was probably acceptable. But over the next slide here, you'll see that's showing on my screen, but not this screen, that there's actually concentric calcification up where that arrow is. And that concentric calcification really precludes the advancement of these sheaths. So CT angiographies are extremely important. Now, I'm going to get technically you guys to advance the slides a little bit because they're not advancing on the screen that I'm looking at, but I can kind of speak to the next little section, which is one of the procedural complications that we have, and that's aortic regurgitation. Now, aortic regurgitation comes in a couple brands. It comes in central aortic regurgitation. It comes in paravalvular aortic regurgitation. The frequency of moderate to severe aortic regurgitation after most TAVI procedures is between 5 and 15%. I think we can probably reduce that by good techniques. But one of the things that's been most important, and I'll have Jeff comment on this, is that at least we understand that moderate to severe residual aortic regurgitation after the procedure correlates with late-term mortality. I think there's more controversy about whether mild aortic regurgitation is really important or not. In the partner study, that turned out to be significant. In the advanced study that Jeff mentioned, it was less significant. But certainly having any degree of aortic regurgitation is something we have to pay attention to. We've worked very, very hard at it. Now, I want to stop at this slide because I want to see if, Jeff, can you see this slide okay? Hopefully you can.
No,
you can't?
No, I don't.
Okay. So this slide, what I'm showing is a piece of calcification on a CT with a core valve in place and a cartoon diagram from the Sinning article that actually shows, in that area where there's extensive calcification, paravalvular regurgitation. So we work very hard from a pre-procedural planning perspective to understand where we might have to do post-dilatation. And we try to understand the hemodynamics immediately after the procedure. Of course, we look at echo. And so, Jeff, I just kind of ask from a discussion purpose, has your approach to post-dilatation or to sizing changed over the last 6 months or a year in order to reduce the frequency of regurgitation?
Yes, one point that you should know, which is not published yet, by the way, as we extended the data set in the Partner 1A, that effect of mild AR mortality is now gone.
Yeah, that makes sense.
So it really conforms more to moderate and severe. No, I think we're using, of course, more of the area and the perimeter work, either on the echo or on the or on the CT, and I think that specific sizing is key. The post-dill, though, is a little bit of a quandary, because I don't think there's any question that further manipulation is associated with a higher stroke rate. I mean, we've seen that in the Vancouver registries, and we had a tendency to that, of course, even in the Columbia. So I think the answer is get the size right, the first time. But in someone like this, if you do have moderate to severe AR, and you have to expand the frame, and you do have to post-dilate, but I think we're reticent to do it for lower grades of AR now.
So the next slide I have up is one that I know it's not a favorite slide for the Columbia group, but it's actually of the aortic regurgitation index. Yep. And I'm not going to speak to the index in terms of its predictability, but I do have the two tracings, and I think there's some physiology that we do pay attention to. And that physiology is that at the end of the procedure, if the aortic diastolic pressure is very close to the left ventricular diastolic pressure, then we know we have a problem. And I think that there may be some differences between core valve and sapien in terms of the utility of this, with how much central aortic regurgitation occurs. But what do you use, Jeff, to assess the degree of aortic regurgitation at the end of this procedure? Do you just use echo? Do you use aortography, or do you use hemos?
No, echo is really our gold standard, and we still do it with transesophageal echo on in every case with anesthesia. As we move to a less invasive modality with maybe conscious sedation, that may be less, and maybe we will be relying more on maybe aortography in those with normal renal function. This index is not, if you have a change in the diastolic pressure from AR, that's not subtle, and you'll see it.
Right.
You'll see it on the echo. And we don't really cross these valves to ascertain this routine basis.
I think that's going to be a difference between commercial use and core valve, because we do. And I think it's because the valve sits higher and it's supraannular and it's porcine and it has less, we don't really see central AR after the procedure. So we do use these. And I think there will be a little bit of diversity of the different camps in terms of that. But I appreciate your comments. We try all three, and I think it's probably going to be device dependent. Now, let me get to the next topic. I'm going to move through some of the stuff relatively quickly, and that's stroke. I'm very sobered by the diffusion-weighted MR data that suggests that there's a lot of embolic debris that goes north after these procedures. Although the clinical stroke rate looks to be relatively low, we are now doing neurologic evaluations before and after by neurologists as part of most of our studies, not just by me, who has a very passing degree in neurologic examination, neurologists, to come for looking for upper modal thumbs. But it appears, I think, in general, that these rates are kind of reducing over time, probably for two reasons. One is that, at least with the newer generation devices, the French size is a little bit lower, so we're manipulating these shaggy aortas a little bit less. And I think we've been also very mindful about over-manipulation of these very degenerative valves. Jeff talked about very care with post-dilatation, but I think that's important as well. So I'm hopeful that these stroke rates will, in fact, be reduced over time. They appear to be within the first 48 hours or so, but and they are higher. And when I talk with patients about stroke, I do say that there is a small increase in stroke rate with TAVR compared to surgical aortic valve replacement. But I think the longer term data, we really have to sort out if there's really a true difference that persists over time. Now, I'm going to stop on this slide, and I'm going to just ask Jeff what he thinks. We have embolic protection devices that are in development phase. I mean, Jeff, what do you think? Are we going to have an embolic protection device with all of our TAVR procedures in the future, or is this rate low enough that it won't be worth the clinical effort?
Well, I think it will be. My feeling is that there's an irreducible rate of embolization just from the expansion of this frame in a calcified valve. And when you look at the hits, that seems to be the main cause of it. And frankly, this whole thing about aortic manipulation and transcatheter crossing is belied by the fact that the transapical stroke rates are the same as the transfemoral. Yeah. So to me, it's as they said in the to paraphrase Bill Clinton's campaign, it's the valve, stupid. Yeah. And there's going to be a shower and I think these devices are going to be important. And if it's low, let's say we get it down to 2%, I think we can still cut it to 1%, and that's important to the patients. But also, if we're thinking of extending this to lower risk groups, we cannot have a rate of 2 or 3%. Yeah. I mean, it has to be in the 1% range.
Yeah. Now I'm going to move on here, but as I'm moving on to the next slide, I want to just throw this out there. I have been impressed that we have used aspirin and Plavix as our anticoagulant, but there's a lot of atrial fibrillation that occurs in these patients immediately afterwards. And I've kind of in the back of my mind thought, maybe the better anticoagulation regimen is going to be heparin, warfarin to prevent some of these embolic events when the strokes occur after 48 hours, which they do in about half the cases. Jeff, is that crazy to think that we should have a low threshold for moving to warfarin, understanding it's a hard patient population to anticoagulate?
Yeah, well, I mean, I hear what you're saying, and of course we have, the Canadian data indicating that their episodes of PAF will correlate with strokes, and these are this is a very stroke-prone population. But the other side of it, of course, is the phenomenon that we saw, for instance, at the late follow-up of partner. The inoperable partner 2s, Bs rather, 1Bs, and we found there was a higher stroke rate going out, past a year. but it was mainly hemorrhagic strokes from falls because they became more mobile.
Right.
So you have to balance that out. And I think, I don't think the AFib story in terms of the PAF post-op is totally sorted out. And I'm still wary about the risks of Coumadin in this population, even though a large percentage of them are on it because of, what 1/3 of them at least have atrial fibrillation. I don't know what it is in the core valve study, but it's a very high percentage.
Yeah, and by definition, they have high CHAD scores, so then you're trying to figure out whether it's really smart to anticoagulate a 95-year-old, But these are the challenges, right? Because bleeding is an issue, and these are the challenges. Let me just touch on one other complication and then just give a quick future perspective, and maybe we have a couple minutes for discussion. Is it, conduction system abnormalities are relatively common after the core valve implantation. I think all of the ones that really expand across the aortic annulus. Pacemakers are required in about 20% of patients. I think that the area is really making sure that you minimize the depth of implantation with the core valve device in particular, keeping it at 4 millimeters or less. Although there was some very provocative data from the Netherlands about the long-term prognosis of a new left bundle branch block that wasn't treated with a pacemaker, we know from the advanced registry now that there really is not a long-term survival difference. Maybe we're getting smarter about the patients in whom we put pacemakers. And the second piece I think that's important information as well is that if there is a pacemaker placed, that there's no significant impact on mortality. So we're very smart. All the patients in the core valve study have pacemakers, temporary pacemakers in for 48 hours if they don't have a permanent pacemaker. We watch it, and I suspect that we'll get better with sizing and indications for pacemaker. We'll probably get that rate to about 20% or so. We'll see in the trial. So finally, I just want to close with this. I mean, we have 2 valves available for us here in the United States, one under investigation with the core valve device and one, of course, commercially approved. I think that these will ultimately be looked upon as first-generation devices because the ability to retrieve and reposition the valve is extremely important. We're going to be going into new frontiers over the next year as we talk about treating valve in valve, so degenerative surgical valves, treating with the transcatheter heart valve. We may need specifically designed transcatheter heart valves for that. We now know that Ian Meredith has presented from the REPRISE study, the self-expanding Sadra valve, which has been kind of reprised. It actually has enough external radial force that it creates a circular annulus with minimal degrees, as reported by Ian, in paravalvular leak. And we've got a couple others that are on the horizon as well, the Portico device, bovine pericardium down at the annulus, and then that's actually the direct flow device from Aortic. I'll fix that on the slide. So the final thoughts are, TAVI is truly transformational technology. It's truly the best for patients who are not ideal candidates for surgery. Jeff's gone through the risk pools. I think we can mitigate the complications by better techniques, but I think that the newer generations of the valves will just be better. And they'll be better because they're going to reduce paravalvular leak, potentially they can reduce stroke, and they'll be retrievable and repositionable. I think that's going to be incredibly important.
And I suppose that plus or minus embolic protection as another. Dr. Karimi asked what your thoughts were about the Portico valve.
So the Portico valve, if I were a simplistic business person and I looked at the core valve device and the Portico device right next to each other, I might see some similarities between the two. It's a long, self-expanding nitinol frame. It looks about the same, but there's some very, very important differences between the two. And one of them is that it's bovine, not porcine pericardium. And secondly, that there is the valve is positioned the annulus with the Portico device, where it's supraannular with the Medtronic device, core valve device. Now, as it turns out, the St. Jude engineers have done a brilliant job with shaping the bovine valve so that even though the valve is out of round, it's not in the round shape in the annulus because it doesn't have the radial expansive force to make it. There's redundancy of the valves that prevents any kind of regurgitation, which is good. Of course, the idea for the Portico device, at least one of the pieces, is that it has less radial expansive force, and maybe the pacemaker rate will be less. And the additional advantage of it is it has some general repositionability. So if you start to deploy it, you don't like the positioning, you can retract the sheath back onto the device again, repositionally, and then go to the device. So these are iterative steps forward. There are some very, very clear design differences between the two, and the design differences were really meant to reduce the complications, both in terms of pacemaker rates as well as repositionability.
That's terrific. Well, it's a wonderful review by two of the leading experts who have led the trials. It's tremendous for me, who see more and more patients referred from all over New England for evaluation. I have to say probably half the people get turned down as it's too early or it's too many comorbidities, and the notion of doing the test to see just how bad is the aortic stenosis as part of the valvular and heart disease, does come up. So a very interesting time, but these are just about the hardest patients to care for.
Well, I mean, Jeff can comment too. I mean, it's Mark Reisman, who's a good friend of many of us, said very, very early on, he says, it's not a procedure, it's a career. And that couldn't be more true. I mean, if you step into this aortic stenosis arena, you have to be ready to deal with an hour per visit with family members, because everybody comes and it's a complicated issue to explain. You have to take care of them before, and then once the valve in place, you own them afterwards. And I don't say own them in a bad sense. I mean, they have things that go on. Jeff mentioned heart failure, but they have a lot of other comorbid diseases that have to be managed, and we all own that. So, I mean, Jeff can comment. I don't think I've ever worked harder in a disease state in my entire career. This is hard stuff, and you have to be committed to it.
Yeah.
Jeff,
we have our unit. Yeah, we have our unit actually interacting with the geriatricians as part of a geriatrics initiative actually at Columbia. But let me just say that there's also a philosophical aspect to this from the patient's perspective that you have to regard. And I learned this from my dad, who, by the way, had an Edwards transcatheter valve. And you have to respect their priorities. They may have a different weighting of complications and trade-offs that we have, and that's where I think the interaction with the patient that you discussed, Jeff, and the family is so critical, because at the end of the day you have to respect their wishes, and they're usually matriarchs and patriarchs surrounded by an array of people, and you have to learn how to communicate with, I think, the patient in a slightly different way than we're used to.
Well, I want to thank both of you for a tremendous program. As these are designed, we're supposed to learn, and my not really knowing much other than we need to call the heart team. It's terrific to get all the, and see the amount of work that's coming, that this is really a field in rapid evolution. I want to thank all the participants for joining us. And also, really appreciate all the input that you have. Any closing comments that you want to leave the audience with?
No, just that I think you mentioned the personal. I mean, I have to say that the quality of life issues that Jeff has mentioned is really important. I mean, people are not looking to run marathons; they're just looking not to be breathless, and that's a very, very important piece to this. Is that they're not really asking for much, except they want to feel better and maybe live a little bit longer. And I think that's the most gratifying part of it, when you see a patient back at 6 months or a year and they've been running around with their grandkids for the last year. That's what really makes a difference.
Yeah.
Oh, that's terrific. Well, thank you both very much. I want to also thank many sponsors of this program, Cardiac Care Live: Daiichi Sankyo, Lilly, Abbott Vascular, Medtronic, and Boston Scientific, who've supported this important educational series. For the audience, please remember to fill out the quiz and questions at the end of the session. That will get you the CME credits. And please stay tuned for our next session that will talk about interventions in peripheral vascular disease. And Dr. Robert Shanefield from the Mass General will join me. So thank you very much for joining this program.
Okay, great.
Okay.
All right. So, Jeff, that was pretty flawless, man.
Yeah, I tell you.